Symptoms of Kawasaki disease: crash and burn, fever, conjunctivitis, rash, erythema and edema, adenopathy, strawberry tongue, red lips, hand and feet disturbances, discommission of fingertip, fever, crash, burn. Clinical manifestation. The clinical course of TD can be divided into three phases. Each unique manifestation, unreasonable involvement of the coronary arteries is the most important manifestation of Kawasaki disease. Occupates last 1 to 3 weeks, marked by sudden onset of high, hectic fever without an apparent resolution. The onset of fever is followed by conjunctival erythema, mucosal changes including dry, cracked lips, and strawberry tongue, cervical lymphadenopathy, and swelling of the hands and feet. A rash which can vary in appearance occurs in 80% of children with KD and may be particularly accentuated in the inguinal area and on the chest. Extreme irritability and colitis in the acute phase may be manifested by tachycardia, shortness of breath, or overt heart failure, and some acute phase lasts until about 4 weeks. Week 4, characterized by gradual resolution of fever and other symptoms. Discommission of the skin, particularly of the finger and toes, appear at this point. The platelet count increased to a significant degree, often over 1 million, and the page herald the onset of coronary artery aneurysm. Risk factors for the development of coronary artery aneurysm include prolonged fever, prolonged elevation of inflammatory parameters such as PSR, age younger than 1 year, or older than 6 years, poor response to the therapy, and male gender. Convalescent phase begins with the disappearance of clinical symptoms and continues until the ESR returns to normal, usually 6 to 8 weeks after the onset of illness. Linear nail increases known as bruised lines. The fingernails may appear during the phase. Kawasaki disease is an acute febrile illness primarily affecting the children under the age of 5. It is characterized by inflammation of blood vessels throughout the body and can lead to coronary artery aneurysm if untreated. The classic presentation includes persistent fever, high fever lasting at least 5 days, which is often unresponsive to typical fever-reducing medications. Conjunctival infection, redness of the white of the eyes without pus or discharge, typically non-oxidative and affecting both eyes. Mucosal changes like red, cracked lips, strawberry tongue, red, swollen tongue with a bumpy surface, and redness of the oral and pharyngeal mucosa. Rash, polymorphous rash, which can take various forms and usually appears within the 4 to 5 days of illness. The rash is non-vascular and can be more pronounced in the coronary area. Extremities changes, swelling, redness, and pulling of the hands and feet, typically in the subacute phase of the illnesses. Acute phase may show erythema of the palms and soles, cervical lymphadenopathy, at least one lymph node greater than 1.5 cm in diameter, usually on unilateral. High opioid Kawasaki disease is considered when a child has a fever lasting more than 5 days, along with 4 of the other principal criteria, although atypical cases may not meet all these criteria. Only treatment with intravenous immunoglobulin, IVIG, and aspirin can significantly reduce the risk of coronary artery aneurysm, the most serious complication of Kawasaki disease. The cause of Kawasaki disease is unknown, but it is believed to be an immune response to an infection in genetically predisposed children. Differential diagnosis test table: infectious mononucleosis, fever, pericarditis, lymphadenopathy, epifocal lymphocytes, scarlet fever, strawberry tongue rash, history of streptococcal infection, toxic shock syndrome, high fever, rash, hypertension, motor organ involvement, Stevens-Jones syndrome, severe blistering of the skin and mucous membrane, stroke, and infectious trickle, measles, rubella, toxic spots, fever, conjunctivitis, cough, and rash. It's crucial to diagnose and manage Kawasaki disease promptly to mitigate the risk of long-term cardiovascular complications. Children suspected of having Kawasaki disease should be referred to a pediatrician or pediatric cardiologist for further evaluation and treatment. So let's sum up. So symptoms of Kawasaki disease: crash plus burn, fever, conjunctivitis, rash, erythema and edema, adenopathy, strawberry tongue and red lips, hand and feet disturbances of disclamation of fingertips, fever, crash and burn. occupies the last 1 to 2 weeks. Marcus sudden onset of high hectic fever, apparent salt mucosal changes, dry, cracked lips, strawberry tongue, cervical lymphadenopathy, swelling of hands and feet, rash which can vary in appearance of cause in 80% of children. KD may be vertically accentuated. Glycolinoaria on the chest, Germany. Its probability colitis is lessened. Until about week 4, characterize gradual resolution of fever and other symptoms. Discoloration of the skin, particularly if the fingers and toes appears at this point. Platelet count increases. Carries factor, glomerular artery, aneurysm, febrile inflammation, elevation, persistent fever, conjunctival infection, mucosal changes, rash, extremity changes, cervical lymphadenopathy, Kawasaki disease, lasting 5 days, opioid management. Only treatment with intravenous immunoglobulin, IgG, and aspirin can significantly reduce the risk of coronary artery aneurysm.